family, and friends, to our discussion on bone health. My name is Colleen Bridges, and I am an NSCA certified personal trainer, a Parkinson's disease fitness specialist, and the head coach and owner of Bridges for Parkinson's. The past few weeks, our bone health series has covered quite a bit of information. First, on what is bone, why bone health is important, how to improve your bone health. And now we're going to discuss the connection between the brain and our bones as it pertains to those living with Parkinson's disease. Maintaining bone health is important to your overall health and well-being. And so, in summary, the skeleton is necessary for facilitating movement, providing a framework for muscles and soft tissue, protecting your vital organs, storage of minerals and fat, and houses the bone marrow and regulates blood cell formation. So there's a lot going on. Now, in recent years, researchers have been examining the relationship between the brain and skeleton and how they regulate each other. One way to better understand this relationship is to determine how it becomes altered by disease. In this case, Parkinson's disease. To help us drill down on this topic, we're going to visit with Renee Rouleau, who is pursuing her PhD in neuroscience at the University of Buffalo. Megan Kelly, who is a neurophysical therapist. And actually, this is really exciting news. She will be joining the Bridges for Parkinson's team in August of 2020. Like next week. We're so excited. And then you know her, you love her, Coach Betsy Lerner, who is a personal trainer. She's a Rocksteady certified boxing coach and a Parkinson's disease fitness specialist. So ladies, thank you so much for taking time out of your busy day to visit with us and help us learn more about the neural connection between bone and brain so that we can, as coaches, be better equipped to serve the Parkinson's community, and so that my fighters and their families know a little bit more information about what's going on and how to really make sure that their bones are as strong as they can be. Now, Renee, I'm going to start with you. Is there truly a neuroconnection between the brain and our skeleton?
Yeah, so the brain connects to a lot of different aspects of our body. It controls a lot of our thoughts, actions, inner monologue, but it also controls a lot of the processes that we don't really think about, like digestion, involuntary movement, muscle contractions, and even bones and bone growth. Nerves actually do run through bones. There are, receptors that can actually activate on your bones to kind of interact with other areas like the muscle to contract and make movement. That's what, ligaments and tendons and all are for, to connect all of these things. But the brain is kind of a huge orchestra, right? It's conducting a lot of different processes. So it would be naive to think that the brain and the bones don't communicate.
That's a great way to think about it, isn't it, Betsy? That it's the conductor of the orchestra that helps simplify our understanding of how the body and the brain work together. Megan, have you got any thoughts on that?
No, absolutely. And I think, that kind of pulls in, how she's saying how everything is orchestrating everything and just the importance of maintaining good bone health and good brain health.
Mm-hmm. That's great. So building off of that question, I've been studying a little bit about how the brain and the bone are connected. And there's these words called crosstalk that has been demonstrated between the skeletal and neural systems at both the physical and functional level. Well, first of all, what is crosstalk, and what does this mean for our brain and bones?
So crosstalk is essentially the conversation that the bones and the brain are having with each other. And this happens through things called hormones, which are these chemicals that get released by the brain into the rest of the body via the bloodstream. And we all know that bone marrow is a huge area of the bone filled with red blood cells that can carry these hormones or chemicals. And so that kind of facilitates the communication between the brain and the bones, telling the bones, okay, you're a little weak right now. We need to get nutrients to you, or okay, we can stop growing right now, or oh, there's exercise happening. Let's create these little like micro fractures in order to get it stronger so it can handle more load. So crosstalk is really that communication between the bones and the brain, sending signals back to each other.
Very interesting. And from the neuro PT side, what are your thoughts on that, Megan?
Absolutely. I think kind of as Renee was saying, there is a huge connection. And I know we'll dive deeper in our conversation about the connection between, Parkinson's and bone health as well, because there is some important components that we need to consider specifically as we're focusing in on the Parkinson's population.
Right. And if the brain is communicating with our bones, which part of the brain actually controls this communication? And is it one part, or is it several parts? How does that work?
That's never a simple answer.
I don't do anything simple, do I?
That's never a simple answer. Which part of the brain controls bones? So there's a pathway through areas of what's called the mid to hindbrain. It's kind of the areas used for functions that we don't really control. So things for homeostasis, so like regulating body temperature, regulating your chemicals and blood flow and breathing and everything. And it's called the hypothalamus. And I'm sure you've heard of the hypothalamus as the feeding, fight, flight kind of area of your brain, but it also controls what's called right underneath it, the pituitary gland, which is the thing that's releasing all of these hormones. And so the hypothalamus regulates this hormone secretion again into the bloodstream to go back down to the bones and tell it to grow or to stop growing, or again, there's load here, so make sure that you're strong right now, and to divvy up all of those nutrients and hormones. So that would be the pathway that is representative in the brain, but I'm sure there's other areas that are not as widely explored. Maybe areas such as the cerebellum, which again control a lot of other aspects of movement like coordination. Perhaps other areas, maybe such as the ones that I'm studying that I'm not going to get into right now, but the hypothalamus and pituitary gland are the two main keywords that you want to keep in mind.
Well, no, I want to go back for just a second to the term crosstalk. How does Parkinson's affect crosstalk, or maybe the other way around? Does crosstalk affect Parkinson's? Probably more Parkinson's affects crosstalk, but, and if I'm wrong, please correct me. But how does that, what happens? Does anything happen there, or is that not so much a big deal as it pertains to Parkinson's?
Yeah, I'm gonna add on. So does the suppression of dopamine negatively impact, and I think this is what Colleen's saying, so the suppression of dopamine, does that negatively impact crosstalk? And is there
Yes.
like a synapse because of the lack of dopamine?
Yes. So dopamine is implicated in bone health, specifically in Parkinson's. You see a loss of dopamine can actually cause a loss of bone density as well. So if you're not getting that dopamine, which people actually don't know, that dopamine can travel peripherally through your peripheral nerves and again throughout your muscles and certainly in your bones. There's more developing research on it now in the 2020s that if your dopamine becomes depleted or downregulated, it does affect this crosstalk to again send signals to the bone saying to firm up, we're carrying a heavy load, or we're getting in the seat of a car, we're trying to stand up. So yeah, absolutely, dopamine loss can affect this crosstalk.
That is so interesting. And so, Betsy, why don't you take the next question?
Sure. Let's see. So if the brain is communicating with our bones, well, we'd already talked about this. Which part of the brain controls the communication? Is it one part or is it pathway? We discussed that. Does the brain control bone development? Ladies?
Yeah, absolutely. Through the crosstalk, through a specific hormone, growth hormone. I'm pretty sure it's just growth hormone. Or follicle, no, follicle stimulating hormones different.
I love
There's a
seeing,
lot of hormones.
I love seeing your brain work.
There's a lot of hormones. TSH, GH, a lot of H's is what I'm reading in the literature. Can control this. So growth hormone is the biggest thing that I've seen. Again, TSH has also been in the literature, which is your thyroid stimulating hormone, which affects metabolism, which again affects the nutrient flow to all of these areas and so forth down the cascade. So it's a really delicate balance. If one of the areas in the system gets messed up, it's going to affect the whole flow.
And that would, I would think, be one of the reasons why some people have osteoporosis,
Yes.
maybe even at a younger age than they normally would.
Yes.
Megan, do you have any thoughts on the brain controlling bone development?
Not specifically on bone development, but going back to, the osteoporosis and Parkinson's, we are seeing a huge increased risk for our Parkinson's population. And it is something that, we do as a healthcare community have to be kind of paying attention to and being considerate of.
I just had a question pop in my mind. As women, we usually get the bone scan, the bone density test. Is there any research out there? Let me see if I can word this correctly. On how fast maybe a woman develops osteoporosis once Parkinson's sets in?
Ooh, that's a good question.
I haven't seen that. I know there's a lot of research.
And does that make sense? Like, okay, here's your DAT scan. That's the bone. To think for a second. PET scan, DAT scan, MRI. You get all confused sometimes. Here's your DAT scan, and then let's say 10 years later they're diagnosed with Parkinson's. We don't always know exactly when, I guess you could say, Parkinson's started, but it would be interesting to see if you base it on when they notice their Parkinson's symptoms beginning, if you go back and kind of see what their bone density changes have been in, say, 2 years or 3 years.
I think that's something that the literature is honestly missing, and maybe more scientists in the field are starting to look at that. But a similar thing, not to go on a tangent, happens with Parkinson's and smell loss. You notice this so-called prodromal symptom happening even 10 or 15 years before you get diagnosed. And it can it's a very high correlation to onset of Parkinson's symptoms and disease onset. So I'm sure that in the future, probably within the next 5 to 10 years, even, there might be more studies longitudinally coming out discussing that correlation.
That would be really interesting, though.
Yeah, absolutely.
Absolutely. I think now that sorry.
Oh, no, go ahead.
I think now that we have found a link between Parkinson's and osteoporosis, I mean, in multiple studies in my research, I've seen that they're significantly higher in Parkinson's patients than an age-matched individual. I think just finding that in general, we're going to see more and more research to figure out, well, why? What can we do to help this?
Yeah, I agree with you.
So I wonder if when someone is diagnosed with Parkinson's, in addition to prescribing levodopa, they start giving maybe synthetic hormones to slow down the progression of bone loss. I think that's probably way in the future, because I would think that you'd have to have a lot of data to prove that. But the other thing I wanted to say is that loss of sense of smell. Everybody, so many fighters that I talk to say, I lost my sense of smell 10 years ago. The doctor told me it was allergies, blah, 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 blah. I wonder at what point are doctors, whether they're movement neurologists or your PCP, as soon as someone comes in and says, I've been experiencing a loss of smell, they do a DAT scan or something like that to determine whether or not they have Parkinson's. I wonder if there'll come a day where that'll be a standard test as soon as we hear that symptom.
Well, and you think about going back to what Betsy was saying, where they potentially in the future, they give them a bone building medication of some sort, whether it was as a shot or a pill. Think about,
Osamax.
yeah, exactly. My mom had to take that. But all that to say, how it would maybe cut down potentially on broken hips, for example, because bones would be stronger and we wouldn't have so many people having to basically stop taking care of the Parkinson's so they can go over here and rehab for the hip, and then their Parkinson's progresses because they haven't been able to really focus on that. I can only imagine that it would help out tremendously with that population. And Betsy, do you want to ask the next question about bone function?
And we wouldn't have to do so many sit stands.
There is that. Hey, sit stands are good. We like them.
I know. You can always do sit stands.
That's right. You're going to be sitting and standing for the rest of your life anyway. Might as well enjoy it. All right, Betsy, ask us the next.
Okay, I think it's question, how does normal brain and bone function connect to movement? And how does Parkinson's affect this?
So I kind of answered neuroscientifically, in, you know, a lot of terms, that question few questions ago. But essentially, I mean, again, you're getting this brain to bone connection. You're getting these neurons that are essentially going from your brain into your spine, all throughout your muscles, into your bones, to pick up on these sensations that you're experiencing, kind of process it in your brain, and then make a movement in order to respond to these sensations, which is in an article way back. If you want to go read that, I'll plug that to understand that process a little more. But this all happens within the span of a millisecond, even less so, microseconds. So I mean, Parkinson's affects that from the dopamine loss. It disrupts cognition, it disrupts movement as a whole, your coordination, your ability to think of a movement. And so it's just going to slow down that process. And if your bones with the dopamine loss can't handle that load anymore, then that movement gets compromised totally.
Mm-hmm.
I'd also like to go back to Betsy's original point of the growth hormone along with levodopa therapy for 2 points. One, there is a lot of research that actually states that levodopa itself has some compromising side effects with bone loss. So levodopa can actually kind of increase the loss of bone density after a long period of taking it, according to a few papers, a few reviews that I've read, and that they actually are starting to preclinically and in some clinical studies give hormone replacement therapy to reduce that risk of osteoporosis caused by levodopa therapy.
You know, if somebody hears it, and I've read that as well, if somebody hears that, they're probably going to internally think, should I stop taking carbidopa?
Yes, that's a huge question. The
answer
is no. Don't stop taking your medication.
No. You know, and I would tell them, you know, of course, I always try to respect my bounds as a personal trainer and group exercise instructor. And I would say, talk to your doctor, because you have to take your dopamine replacement. You cannot stop taking that. But there are things that they can give to supplement and address the bone density issue, right, Megan?
Mm-hmm. Absolutely. And, you know, there's so many factors that go into bone loss with Parkinson's. You know, number one is limited mobility, especially as the disease progresses. So the importance of keep moving, because when we exercise, those muscles pull on the bones, that keeps them strong. You know, another side of Parkinson's is we get out less typically, which is less vitamin D, which, you know, vitamin D and calcium are just so critical in bone health. Then there's the medication side. As Renee was saying, you know, maybe some of the medications further creating bone loss. Then the malnutrition side, because you can't smell, it's not, sometimes that can affect taste as well. And you don't feel like eating. And then we see, malnutrition and weight loss. Then, that leads to decreased muscle mass, which leads to decreased bone mass or, bone strength. So there's just so many factors that play into how Parkinson's affects bone health. And that's where personal training and physical therapy comes in, because we get to play a fun role in like performing the weight bearing, keeping muscle mass up, reducing falls, and keeping you moving as long as possible.
Speaking of,
in last week's article, there was a whole section on nutrition. And I highlighted this section when I gave it to my folks, all about calcium and the sort of the caveat about calcium and the positives, yet sort of the negatives, and how you have to consume calcium with protein, when not to do it, when to do it. And folks wrote to me and said how important that particular piece was. So can you talk a little bit about calcium and its effect on bone health? Because we were brought up, drink milk, 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 it's good for your bones. And now I read last week, well, it is, but you got to do this, you got to do that, don't do this, don't do that. So can you share with us a little bit about calcium and bone health?
So calcium deficiency is bad, but calcium, I mean, any sort of vitamin that's, again, it's a delicate balance. So any over saturation of vitamins can also be bad. It's also not calcium that directly works with the bones. It is, but you need all of these other vitamins to kind of chaperone it, like vitamin D. That can definitely help to chaperone and kind of make calcium more effective at its role in strengthening bones. Megan honestly might be able to speak a little bit more into how this can work clinically, but because I don't want to bury all down in the receptor details.
No, absolutely. I mean, calcium and vitamin D are huge, and vitamin D deficiency is pretty common in just the general population as well. We're spending less and less time outside, and we're told to put sunscreen on and, do all the things which are good, but we're seeing, kind of across the board lower vitamin D levels. And I think it's important to realize that you only need 15 minutes a day of vitamin D to get what the body needs. So no one has to spend hours outside, but even just taking that 15-minute walk with your loved ones or sitting outside for 15 minutes, as well as the whole nutrition side, is really beneficial for bone health.
well, and that kind of leads us to our next question. You hear a lot about Parkinson's and the gut. Do you think that nutrition plays a role in how well the brain and our skeleton, our bones connect? I mean, certainly what goes in is going to power your body and produce energy and affect how we move. But do we have to, there's no specific diet that we should be on for Parkinson's. It's always just eat a well-balanced meal. But how deep do you think our nutrition goes in helping the brain and the bone connect?
Yeah, I mean, there's a lot of research on gut microbiome for a number of diseases like depression, Alzheimer's, other forms of dementia, and Parkinson's, even as we were discussing before, as predictors of Parkinson's disease. In fact, there was a study that came out, I think 1 or 2 months ago, that actually found a biomarker in the gut for Parkinson's disease, which was really interesting. Of course, further research has to be done on that. Right. But it's really cool that we're able to use the gut as this predictive kind of mechanism for who might be diagnosed later in life. I think nutrition definitely plays a role in that, in keeping your gut microbiome, living to the fullest, which means also probiotics, yogurts, kombucha, if that's your thing, fermented sauerkraut, again, vitamin D. So your milk, any sort of leafy greens, folate is actually huge too. That's a big one that I've been seeing in literature. And protein, because protein helps keep the muscles, able to be load bearing. which again keeps the bones able to bear heavier loads. So I think that definitely helps the brain better connect to the muscles and the bones help to connect back to the brain.
And once again, for Parkinson's, we hear a lot of don't overeat your protein, eat your protein here and take your medicine here. And so then people almost become afraid to eat their protein, but they've got to eat their protein. It's just a matter of kind of planning it in conjunction with their medication. Do you hear that a lot, Betsy?
Yes, yes. And what amazes me is some people just throw all their food together. They're eating protein with this and their calcium and their pills, and they make a sandwich of their protein and, a piece of ham and their levodopa and then another piece of ham. It's crazy what I hear. And then some people go to the other end,
Yeah.
And make sure you're drinking enough water with your medicine.
Exactly.
So it will get all the way down.
That's right. Yeah.
Well, I have a rule that at the end of class, whatever they're drinking, that bottle has to be empty. And Colleen knows it's about me. I'm big on hydrating.
Yep, that's important.
So I see them guzzling, so I can't see them at the end of class. Yeah, it's empty.
Well, this next question has to do with bone mass, peak bone mass, and as we age, which peak bone mass is usually reached around 29 years of age, 30 years of age. And research suggests that low bone density, I'll get it out in a minute. Research suggests that low bone density at peak bone mass, so when you're between 29 years of age and say 31, that it may lead to higher chances of dementia. So in other words, the lower your bone mass is, the higher your chance is later in life of developing dementia. And Renee, I'm actually going to start with you. What are your thoughts on this? And then Megan, what do you see and experience in the clinic on a day-to-day basis? Renee, take it away.
So we were just discussing this before we hopped on to the recording part of the session. But I think it is definitely a question of like what causes what, as Megan said. And for me, the way that I put it is the chicken and the egg, conundrum. What's causing this higher chance of dementia? Is it peak bone mass, or does higher chance of dementia stop movement, which causes, a kind of positive effect? So I think that it's definitely, once again, an underexplored area of research that I really, really hope gets the chance to be explored either through clinical studies or mouse or rat models to look at mechanistic functions, which is what I do, or, even in case studies, people just documenting this at the clinic and then going back and looking for these correlations.
Very interesting. Megan, what do you see in the clinic?
Yeah, absolutely. Well, I think if we just think about what exercise does, it does so many great things. But one of the great things it does is it promotes blood flow to the brain. And so I think, as more research comes out, I think, if you're exercising, even if you already have dementia or you have a big family history of dementia, as you exercise, that blood flow is going to help slow and help reduce the risk of dementia. I was finding, again, the research is kind of inconclusive at this time, but we are finding pretty big benefits of exercise midlife and slowing and reducing the risk of dementia. Research says anywhere from like 30 to 45%. So until we really know, I say, hey, let's just all keep exercising until we know, because it's not going to hurt you either way.
No, not at all. And we've actually already talked about this, but my next question was, how does a neurological disease like Parkinson's affect bone health? And it goes back to that answer right there. We've already mentioned it earlier. We have to keep moving. But from a neurological perspective, and Renee's already answered this, that lack of dopamine does affect long-term our bone density. And then you add on levodopa, which we know can affect bone density. So truly, we need to be promoting exercise your entire life. It's not something that you do for a short time in your life and then you think, oh, well, I'm going to be good for the next 10, 15 years. It's something we have to do forever. It's a journey, not a destination.
To
Absolutely.
add on to that, I think that Parkinson's disease is primarily treated as this brain disorder, right? It's a brain disorder that comes out of movement. That's not really the way to look at it, and that's not how we should be looking at it in the year 2023,
Yeah.
when we know that it's so many other factors that can affect us peripherally. We should be focusing on it as a holistic disease, right? It affects not only your brain function, but your body, your emotions, your life in general. So it's really about making sure that the patient and the fighter's quality of life is not as affected by the disease. And that means treating everything, not just brain chemicals.
Amen. I like that. Which leads me to Megan. What drills or exercises, 2 or 3, do you recommend to our fighters and others who might watch this that are maybe living with low bone density, or they don't want to develop low bone density? What drills or exercises do you encourage them to do to improve their bone health?
Well, absolutely. If you don't use it, you'll lose it. So staying on top of kind of where you're at. So if you're starting to notice that things are hard, ask your personal trainer, ask your physical therapist, and work on those things before they're super challenging. But specifically, we need weight bearing exercises. So weight bearing is anything that puts weight through the legs. So walking, sit to stands, dance classes, go into Bridges for Parkinson's classes, just putting weight through your bones. Again, it's going to pull, your muscles are going to pull on your bones and keep them strong. We really have to think a lot about fall risk and falls. Balance exercises are critical. A lot of my Parkinson's patients, I highly, highly, highly suggest once a year come in for a balance assessment to a physical therapist, and just to kind of stay on top of things, because once you have, repeated falls, every time you fall, the risk of fracture is greater. And we know once you have a fracture, a lot of times that leads to a period of not being able to exercise as much. And in the Parkinson's population, we know exercise is everything. So if you have a stent where you can't move as much, it can start to kind of increase your progression. Because of this season where we're at medically, we don't have a cure for Parkinson's, but we do know exercise slows progression.
Mm-hmm.
And that's really important for us to really focus in on that, because that is one thing that we can control, is moving our body as much as we can. But my favorite is those good old sit to stands.
And you know what? We do them at Bridges for Parkinson's Rock Steady. And when we pull the chair out and we start, we're doing those sit to stands. Like,
I did them this morning in a strength class. I do it every Monday morning. That's the first thing we do. 10 sit to stands, like it or not. Like it or
I
not.
love it.
I'll use one of my private clients as an example. We started working together probably about a year ago, and she started after she'd had a hip replacement, and she's a little bit overweight, but wheelchair bound, but lives on her own. And I said, what are your goals? And she said, I want to be able to be more mobile around the house without being afraid that I'm going to fall. And she does have help that comes in. I said, well, you know what that means. And she now is able to get on and off of her recumbent bike by herself. She's able to actually do bathing by herself. She's able to stand at the kitchen counter longer and prepare her own meals. Yes, she still has somebody come and help her a couple of days a week, but she said, as a matter of fact, she said today, she said, I'm so glad that I started exercising and doing these sit to stands in particular, and doing something 3 to 4 times a week. She said, I don't even want to think about where I would be if I did not do these exercises. And I said, I'm so proud of you. It is hard. It's not easy. There are days that people are not going to want to get up and, as we like to say, fight back. But really, you have to. You have to, not just for you, but I always tell everybody it's a gift to your family. And we want to keep our independence. So it's definitely something that we need to do. Well, in closing, what is one point about bone health that every individual living with Parkinson's disease should know and incorporate into their life? And Betsy, I'll start with you.
Action equals reaction. And I'll leave it at that.
Yeah. Renee, what you got?
Use it or lose it. That's all. I'll leave it at that.
Short and sweet.
Short and sweet.
Megan?
Move your body.
Motion is lotion.
Absolutely.
And like I said earlier, exercise is a journey. It is not a destination. And having a team on your side who understands Parkinson's disease, who understands the ways that you need to move and how you move about in just your everyday life is important. It's critical. So we at Bridges for Parkinson's love being alongside you as you journey through Parkinson's, and we want to be here to support you any way that we can. So hope that this podcast, this recording has helped you learn a little bit more about bone health and that connection between the brain and the body. It's so important, and it really does. They do talk to each other, right? And
Absolutely.
this has been a lot of fun. Renee, thank you so much. I know you've got to get back to writing and working on that PhD. We're so proud of you. And Megan, thank you so much for your time. We're so excited about having you at Bridges for Parkinson's starting next week. And
Welcome to the family.
yeah,
I know, I'm so excited.
And Coach Betsy, you know I love you, and so thankful for you and all that you have contributed to this podcast. So without any further ado, have a great night. Thank you, ladies.
Thank you, guys.
Thank you.
Thank you.